thankful to the Pakistan Society of Hematology who gave me opportunity to talk about the topic of diagnostic approach to patient with persistent lymphocytosis. So I'll guide you through the definition and various sequential approaches which employ good clinical history, physical examination, morphological appearances, and flow cytometry. And I'll sum up it with a diagnostic algorithm for you to employ in your clinical areas. So what is lymphocytosis basically? So it's a count of over 4,000, absolute lymphocyte count of over 4,000 per microliter in adults, over 7,000 in older children, and in infants it's more than 9,000. So, as I already said, I'll not be overstating that a good clinical history and physical is 50% of the diagnosis. So, for any clinical workup, this is the most important uh, initial part you should do. And in cases of lymphocytosis, you can couple it with the first tool, which is the morphology. And uh, with this scenario, you have different approaches and different difficulty levels. You have a very simplified case of 2 + 2, 4, to cases where you will scratch your head, to cases where you really clench your fists. So to give you an example, for example, this is an 8-year-old kid with fever, sore throat, and lymphadenopathy. And on the right, you are seeing atypical lymphocytes, large lymphocytes with steel blue cytoplasm, open nuclei, which is a characteristic downy cell, which you see in EBV infection. So this is infectious mononucleosis. So straightforward case. And again, you may have seen a lot of these small lymphocytes with high NC ratio, and in the background you do have smudge cell, another walkaway in a 57-year-old male with fatigue, fever, and weight loss. And similarly, as I already mentioned, 60-year-old male, pancytopenia, splenomegaly, this is half of your diagnosis. You can diagnose hairy cell leukemia just on the basis of clinical history, 50%. And when you see these medium-sized cells with shaggy borders and hairy projections, you tend to have good diagnosis. And similarly, an 8-year-old patient with abdominal mass, fever, weight loss, and you see these again, medium-sized cell with relatively open chromatin, lots of cytoplasmic vacuoles, and you tend to get to the diagnosis of Burkitt's-like morphology. Uh, Now we come to the area where you really want to scratch your head. So these are the highly atypical lymphocyte. You can see this high NC ratio, and they're very cleaved, angulated with irregular nuclear outline. And you must be wondering whether this is a reactive lymphocytes or a neoplastic one. By the way, this is a case of a kid with a nagging cough and had pertussis. So this is a case of pertussis where you can see these highly atypical lymphocytes. Again, very similar cells, highly cleaved nuclei, high NC ratio, and you must be wondering another phase of pertussis. By the way, this is in a 60-year-old with the diagnosis of mantle cell lymphoma. So they may have similar morphology, and that's what I mean when you scratch your head or you clench your fist while looking at the different flavors of morphologies. So you may have seen in your routine practice this cell, which is a large granular lymphocyte. And again, depending upon the clinical scenario, these could be normal LGLs or may be part of a neoplastic process such as LGL leukemia. By the way, this is likely a case of post-splenectomy. It's a benign LGL. And this case, the similar large cells with lots of granules, and whether it's a reactive or neoplastic, this was a case from a LGL leukemia. So again, similar morphologies, but different disease processes. And everything which glitters is not gold. So every cytoplasmic vacuolation is not Burkitt's. So you may see it in lymphoblastic lymphoma, you may see in some reactive lymphocytes. Uh, Again, very atypical morphology, a lot of convolution in these lymphocytes, and almost giving you appearance of a flower cells. And these are, by the way, called flower cells, and they are characteristically present in adult T-cell lymphoma leukemia. Is it is it unique to ATCL? The answer is no. You may see in T lymphoblastic lymphoma, other type of leukemias. You may see in blastic variants of mantle cell lymphoma. So you can see these kind of flower cells. So how to deal with this dilemma of reactive versus new plastics? So what next tool you have to answer this question of reactive versus new plastic? So the answer is flow cytometry. So basically, flow cytometry is the easiest way to prove clonality in B and T cell lymphoproliferative processes. In B cells, you can do kappa lambda light chain evaluation for restriction of either kappa or lambda light chain. In T cell, you similarly can do it with T cell receptor evaluation, and you can couple it with pan T cell expression, and you can look at the variable intensity and loss or gain of different T cell antigens. So this is the case of reactive B lymphocytes, and these are the lymphocyte gate. And on the right side, you have these CD19 positive B cells, and this population is expressing both lambda as well as kappa. So this is a typical reactive polyclonal population of B cells. Similarly, this is again, lymphocytes are gated, and these are these T cells, and there are variable T cells, and these all of these pan T cells, for example, CD5, cytoplasmic CD3, CD2, CD7, they're all expressing same intensity of expression of these antigens. There is no loss, and there is no dimness or heightened expression in these lymphocytic populations. So these are reactive T lymphocyte. In contrast, you may have a T cell population, for example, over here, which does not show CD8, which means there is a loss of CD8. Similarly, there is a loss of CD7, and the CD2 is expressing in few tumor cells, while CD4 and CD5 are expressed in good intensity. So this is a case of new plastic T cells. So you have this tool to basically address this question of whether the given lymphocytosis is reactive versus new plastic. So coming to the, again, back to the clinical, physical, and morphology, which is the gateway to your differentials. And once you decide whether the lymphocytosis is reactive or clonal. Among reactive lymphocytosis, you have a long list of differentials. Mostly these are due to infections, and viral being at the top of them. And you can see EBV related CMV, HIV, measles, mumps, and other viruses. Bacterial infection generally do not cause lymphocytosis. But there are certain bacterial infections such as pertussis, brucella, cat scratch disease. They are associated with lymphocytosis. Among parasites, you have toxoplasmosis and malaria. In our part of the world, tuberculosis is very common, so that also is associated with lymphocytosis. The non-infectious causes, you may have thyroid disease, Addison's disease, inflammatory bowel disease, different vasculitides. They may show lymphocytosis. Certain drugs in a hypersensitivity reaction may cause lymphocytosis. And as I already mentioned, post-splenectomy, you have lymphocytosis, and majority of those lymphocytes are LGLs, and they may persist for years to come. Then you have persistent polyclonal B-cell lymphocytosis, typically in a smoker female patient, which is a benign disorder. So once you have constructed the differential diagnosis with good clinical history, and you do certain serological testing for different infectious diseases. Then for thyroid testing, Edison disease testing, you can come up with a particular or specific diagnosis. So the question is when to go for flow cytometry. Is there a criteria? So I've laid down these 5 criteria which help me a lot to decide whether the current lymphocyte should go for flow cytometry or not. When you see abnormal cell in peripheral blood which are not going either to south or north, you can order flow cytometry. When malignant etiology is clinically suspected, or you see cells which do not match with clinical history. For example, you have a typical clinical case with a suspicion of, say, infectious mononucleosis, but you see malignant looking cells in the peripheral blood. So you can order cytometry to look into it, whether it's a reactive condition or a malignant condition. If the lymphocyte persists for more than 3 weeks, or older patient with count over 6,000, so that prompts you to go for flow cytometry. So what you do in cases of lymphoid malignancies, so you can easily diagnose in most of the cases the B cell lymphomas and the T cell lymphomas. Among B cell lymphomas, there are different B cell markers which are highlighted on the top, the CD20, 19, 79A, and CD22. And I've categorized the B cell lymphoma under 3 categories. There is another way of doing it, which I'll briefly mention at the conclusion of my talk. So the B cell lymphomas I divide basically for purpose of understanding into 3 types: the CD5 positive lymphomas, CD10 positive lymphomas, and CD5 negative, CD10 negative lymphomas, so dual negative lymphomas. Remember that B cell lymphoma means they express most of these pan B cell markers. The T cell lymphomas, they express the pan T cell marker, and their expression is variable. And the T cell pan T cell marker, they include CD3, 2, 4, 5, 8, 7, and CD1, etc., etc. So among CD5 positive lymphomas, you have 2. One is the CLLSL, and you can include MBLs in the definition, under the definition of SLL-CLL, because majority of your MBLs, they have the similar phenotype of SLL-CLL. And then you have mantle cell lymphomas. So these are the 2 common CD5 positive lymphomas which you encounter. The CLL-SLL has small cells, round nuclei, and generally they have smudge cell in the background. And by phenotype, they do show CD5 positivity. The CD20 is characteristically show dim expression, and so is the light chain. CD23 is positive. CD10 and FMC7 is negative, and cyclin D1 is negative. And these cyclin D1 and CD23 tends to differentiate it from its other CD5 positive lymphoma, that is mantle cell lymphoma. So this is the CLL case, and you see that the tumor cells, they show CD22 positivity. How can I use my cursor? All right, so these are CD20 positive, CD23 positive. CD20 has a dim expression. FMC7 is characteristically negative. And I'm missing one slide. That's fine.
You can use your cursor.
Yes.
You can use the cursor of your laptop.
Okay. All right. All right. So again, you can see, so this is a B cell phenotype. This is CD22 expression. CD22 is dimly expressed. FMC7 is negative in these cells. again, CD19, which is a B cell marker, is expressed, and they are expressing CD23. One slide is missing where I showed that these are CD5 positive and CD10 negative. I think the slide is not here. MBLs is a distinct entity in the current 2016 update. So it is a monoclonal, by definition, it is a monoclonal B cell in peripheral blood of less than 5,000 per microliter with absent extramedullary disease, even if cytopenia or disease-related symptoms are present. And majority of these cases of MBLs have a phenotype of CLL, but remember, non-CLL phenotypes are also seen. Generally a benign condition, but most MBL is considered a precursor lesion in virtually all cases of CLL and SLL. The mantle cell lymphoma has generally small cell, uniform size. The nuclei are irregular, and sometimes they are so irregular that they may take the shape of flower cells. Again, CD5 positive. In contrast to CLL, they are bright CD20 positive, bright light chain restricted. Again, cyclin D1 positive, FMC7 positive, another contrasting feature with CLL, SLL. CD10 negative and CD23 negative. So this is mantle cell lymphoma, CD19 positive, lambda line chain restricted, kappa is negative, CD5 positive, CD20 strongly positive, FMC7 positive, again CD20 strongly positive. CD10 lymphomas, you have follicular lymphoma, which is CD10 positive, apart from the regular B cell markers. They are BCL2 positive, CD23, CD5, and cyclin D1 negative. So this is a case of follicular lymphoma, where you have CD19 positive cell which do not express CD5, do not express CD23. However, these CD19 positive express CD10 with lambda light chain restrictions. It's a case of follicular lymphoma. Another CD10 positive lymphoma is Burkitt's. Again, small to medium sized cells, conspicuous nuclei, and vacuolated cytoplasm. CD10 is strongly positive, strongly CD20 positive, light chain restriction. And if you have bone marrow fine, you can do Ki-67, it will show 100% nuclear staining. In contrast to B lymphoblastic lymphoma, they are TDT negative and CD34 negative. So this is how the clinical history, the morphology, and the phenotype favors or makes the diagnosis more clear. Again, pre-B-ALL, as I mentioned, in contrast to Burkitt's lymphoma, the pre-Bs are TDT positive and CD34 positive. And generally, in contrast to Burkitt lymphoma, CD20 is either negative or very dimly expressed. CD5, CD10 negative lymphomas. So we have lymphoplasmacytic lymphoma, which have a nuclear shape of a plasma cell, but the nuclei of a lymphocyte. So it does not have any specific marker, and the accompanied plasma cells and some of these tumor cells may show plasmacytic expression. Hairy cell leukemia has a characteristic phenotype. They are CD11C positive, CD25 positive, CD103 positive, and annexin A1 positive. So there's a case of hairy cell leukemia. Again, lambda light chain restricted, CD20 positive, CD5 negative, CD10 negative, FMC7 strongly positive, and these are CD11C positive, CD103 positive. So this is a case of hairy cell leukemia. So that concludes the B cell lymphomas, and among T cell lymphoma, there are a long list of T cell lymphoma, but I've just mentioned few which you encounter in your clinical practice, and these include T cell prolymphocytic leukemia, T cell large granular cell leukemia, and then adult T cell lymphoma leukemia, mycosis fungoides, Sézary syndrome complex, and then T lymphoblastic lymphoma / leukemia. I'll give a couple of examples. So this is a T cell PLL. Again, lymphocytes are gated, CD8 negative. However, CD4 is positive, strongly positive in these cells. These are the CD3 cells. And this is a alpha beta gamma receptor positive, and gamma delta is negative. So this is a case of T cell PLL. Few other CD5 positive. And this is the PTALL, and you see I've mentioned that the floral cell may be seen in T cell lymphoblastic leukemia as well. So again, they have characteristic phenotype of cytoplasmic CD3 positive, surface CD3 negative, and they may have variable expression of different T cell markers. So they do express CD34 and and TDT. So this is the case of pre-T cell ALL. So far we have discussed various differential diagnoses and a sequential approach, and I promise that I will give you a sort of algorithm at the end, and this is the algorithm I was talking about. So you have a case of lymphocytosis, so you get a complete history and a physical examination, and I did emphasize over the importance of these detailed clinical history and its relevance to the differential diagnosis and a proper diagnosis. So the next is you see the cell under microscope, and then you order flow cytometry. Flow cytometry will bifurcate it to either clonal lymphocytosis or a reactive lymphocytosis. Among the reactive lymphocytosis, you raise a differential diagnosis of viral infection, bacterial, protozoal, autoimmune infections, drugs, etc., and with the help of good clinical history and relevant testing, specific testing, you come up with a diagnosis. And this diagnosis is managed accordingly. So by the way, majority of these lymphocytosis in reactive conditions are due to these underlying condition. If you take care of these underlying condition, the lymphocytosis generally goes away. So among the left side, the clonal lymphocytosis, you have T cell lymphoproliferative disorder or T cell lymphomas, and you have LGLs, mycosis fungoides, PLL, adult T cell lymphoma, leukemia, etc. Among B cell, you have the B cell lymphoma. So I've done a different algorithm here for your understanding as well. So either you separate it on the basis of CD5 positive, CD10 positive, and CD5, CD10 negative lymphoma, or you may have a CLL phenotype and non-CLL phenotype. So among CLL phenotype, you have CLL when the absolute count is equal to or greater than 5,000, and monoclonal B cell lymphocytes when the count is less than 5. The non-CLL phenotype, you have to make diagnosis of these lymphomas, which we have discussed: follicular, mantle, hairy cell, LPLs, marginal zone, Burkitt's, etc. So once you diagnosed these lymphomas, the next logical step is basically the staging, and where you may end up getting bone marrow biopsy, CT or PET CT, etc. And once the staging is accomplished or done, the patient is ready to receive specific chemotherapy. Thank you very much. Hello. Yes, Marine, I'm done.
Yes, thank you very much, sir.
Okay, all right.
The problems of connections are everywhere.
Okay.
So I'm sorry for a bit interruption in my voice. Thank you very much, sir, for telling us wiser about approach to a patient of lymphocytosis. We really enjoyed the talk, and there are more than 70 participants, the residents of hematology and residents of oncology, residents of medical oncology, and residents of radiation oncology. Everybody has enjoyed the talk and will be having question and answers in the end. Thank you very much, sir, for joining us. Right. So we go to our next talk. We are really honored to have Dr. Toby and Professor Leslie on board. So our second speaker would be Dr. Toby R. from Oxford University Hospital, Oxford, United Kingdom. Thank you very much, Toby, for being here. So he'll be educating us for